Okay, sir. So we are live in three, two, one. Please start, sir.
Yeah. Good evening, everyone. On behalf of Bayer, I would like to welcome you all for this scientific meeting. So we are good to go, and our first presentation is with Dr. Ovesh, who will be giving a talk on aflibercept treat and extend long-lasting benefits and reduce treatment frequency in wet AMD. So I would like to introduce Dr. Ovesh. Dr. Ovesh is a highly skilled ophthalmologist and eye surgeon with over 9 years of comprehensive clinical experience, having honored his expertise at elite institute such as All India Institute of Medical Sciences AIMS. He holds a specialized fellowship in medical retina and cataract from Susrut Hospital, Kolkata. Dr. Ovesh specializes in diagnostic and management of retinal vascular disorder, diabetic retinopathy, and macular pathologies. His procedural expertise include intravitreal anti-VEGF administration, complementing his medical retina practice. Dr. Ovesh is highly volume surgeon with many successful procedures, including premium cataract surgeries, refractive procedures, LASIK and ICL, and minimally invasive glaucoma surgeries. He is dedicated to delivering evidence-based, compassionate patient care. So, Ovesh sir, please.
Yes.
Yes.
Good evening. So I start with the presentation of aflibercept treat and extend long-lasting benefit and reduce treatment frequency in NAMD. So next slide. So these are the disclaimers for the presentation. Then current unmet needs in the treatment of NAMD patients. The need for reduced treatment burden with current anti-VEGF agent for patient is increasing. 72% of respondents to 2022 EURETINA clinical trend survey of agreed that quantity of injection is the largest unmet need with the current anti-VEGF treatment. So these are the proportion. So next slide. So next slide is variation in VEGF suppression time between patient indicates a need for treatment individualization. So mean duration of VEGF suppression is around 71 plus 18 days with aflibercept, and duration of VEGF suppression with aflibercept varies up to 16 weeks in patient with neovascular NAMD. So implementation of treatment and extend regimen in clinical practice. In the aflibercept treatment and extend protocol, treatment is initiated with 1 injection per month for 3 consecutive doses. The treatment interval is then extended to 2 months. The patient receives an injection at every visit with no monitoring between the visits, and the time between the treatment is gradually extended until fluid recurs or visual acuity declines in order to determine the maximum treatment interval with disease stability. Treat more frequently if the vision and the anatomical status deteriorate. So we treat the patient extend until the fluid recurs and visual acuity declines. So decrease in interval to previous stable interval, and maintaining the patient at this interval will minimize treatment burden and fluid fluctuations. So durability of current anti-VEGFs. So different trials are done for ranibizumab, brolucizumab, aflibercept, and faricimab. So different trials will start with the ranibizumab treatment and extend trials, which are done, and we can see the different trials like TREX, can treat Lucas fluid, and different type of fluid trials. We can see the improvement in vision of 8 letters, and 18 injections are required in TREX trial, then 17 in Cantriate, then 16 in Lucas. Fluid trial requires 17 injection, while the improvement in the vision is very less in fluid trials. In Hawk and Harrier trial, this trial is of brolucizumab. Only 39 to 45% of patients were maintained on Q12 dosing by week 96. So we can see the in Hawk trial only 45% were maintained, and in Harrier only 39% were maintained. Although the injections were slightly on a lesser side by 1 injection, but it is not that good drug because it causes inflammation and different problems in the eye. And so now we comes to the faricimab trial. TENAYA and LUCERNE trial. So up to 25.8% of the patient receiving faricimab 6 mg could not be extended beyond Q8 at year 2. Patients receiving faricimab Q8 are likely to have an increased injection burden versus those receiving aflibercept 2 mg Q8 fixed dosing, owing to additional loading dose of faricimab. So this trial requires an additional dose of 4 injections rather than 3 injections. Duration, same slides are showing that for faricimab require 4 injections. So extension up to Q16 depending on the distance acuity assessment at week 20 and 24, and no option to readjust treatment interval after week 24 in year 1. Mandated to receive Q8. Now we come to ATLAS trial, which is the most important trial for aflibercept, in which it is for treat and extend. So 2 weeks interval and 4 weeks interval patients are compared. So at 52, you can see the at 52 weeks, it is the primary endpoint, and at 96 weeks, it is the endpoint of treatment. So these are the treatment will be according to the treat and extend dosing regimen, means plus minus 2 weeks, no change, or minus 2 weeks, and same for 4 weeks interval. So when to extend, when to maintain, and when to shorten the interval of the treatment. So when to extend, when there is no fluid present in the follow-up, no loss of 5 letters of ETDRS letters, no increase in retinal thickness of 100 microns, no new neovascularization, and no new macular hemorrhage. When to maintain, when there is slight residual fluid or the fluid is decreasing and other things are the same. When to shorten the interval, when there is new fluid present or persistent or unchanged or increased fluid present, or there is loss of 5 letters, there is increase in retinal thickness of 100 microns, there is new vascularization, and there is new macular hemorrhage. So this is the important thing which has to be done, when to shorten and when to extend. So according to Atler, there was improvement in vision of 7 letters in 2 weeks trial, and in 2 weeks interval, and 10 injections are required. So almost similar number of injections were required in 2 weeks treat and extend and 4 weeks treat and extend. And proportion of patients at 16-week interval at the final visit was 41% in 2 weeks one and 46% in 4 weeks one. So by 96 week, 56.9% to 60% of patients were maintained at interval of 12 weeks and beyond. So both was very similar, like 2 weeks, we can see like 56%, and in 4 weeks, 60%. And the mean last injection interval was 12 plus 3 in 2 weeks group, and 12.5 plus 3.6 in 4-week group. So in Atlair, up to 96.2% of patient extended to a Q16 maintained this interval to week 96 with aflibercept. So up to 96% was there. And vision gain achieved in year 1 was maintaining to 96 to week 96 with fewer number of 4 injection in year 2 in both treatment groups. So you can see the same thing was in the slides and in the graphs. So new question can come. Can aflibercept 2 mg achieve RCT-like outcomes in clinical practice? So this is a study done by Jaggi, and this is shown that mean number of injections given in the first year is 11, second year is almost 10, third year is 10.5, and 4 years almost 6. So 35% of the patient achieved 3 consecutive Q16 interval, means the patient were stable for 3 consecutive 16 weeks intervals. That is when exit criteria is met. So regularly 12 weeks control visit allow timely identification of potential recurrence when treatment should be resumed. So this is another study by Maruko, which is saying that vision improved from the baseline to the year 2 with aflibercept treat and extend with up to 61% of patient achieving dose of 3 months, dosing intervals of 3 months. So mean number of injections was 7 for first year and for second year is 13. So by 2 years, 60% of eyes were being treated at interval of 3 months. In study by Taipale, up to 67% of patients treated with rapid extension protocol achieved dosing interval of 3 months after 2 years of proactive treat and extend with aflibercept. So same thing is given like for number of injections and all. And at years 46 at year 2, 46% and 67% of patients were being treated at interval of 12 weeks and beyond in treat and extend anti EM and TER group respectively. Next slide. So 2-year real world result of aflibercept using treat and extend regimen in neovascular AMD and PCV. So there is improvement from baseline of 0.75 plus minus 0.41 to 0.6 to 0.41 at 3 months after treatment initiation and further improvement to 0.6 plus minus 0.46 at 2 years. So number of injection within 2 years treatment was around 14 at 24 months and the treatment interval was extended more than 16 weeks in 60% of cases and 80% of PCV cases. So this is the RWE supports the long-term effectiveness and durability of aflibercept 2 mg with proactive treat and extend regimen. So different trials you can see in England and in Switzerland, TRINET trial and JAGI. Same thing is being told that there is improvement in vision and less numbers of injections are required with aflibercept. Aflibercept 2 mg has set a high bar for patient outcome in clinical trials with a proven efficacy in the clinic. Of all the available anti-VEGF agents, aflibercept binds the most diverse range of VEGF ligands and the key driver of the retinal disease. As supported by the wealth of data, aflibercept 2 mg has shown to deliver improved long-term outcomes with regular proactive treatment. Aflibercept treat and extend offers the flexibility to achieve and maintain vision gain with interval of Q4 and Q16 while tolerating some residual fluid and reducing treatment burden. So with this, the slides are over and
Yes.
this part is done.
Done. Thank you, Uwe sir, for the wonderful talk you have given. So now next, I would like to invite Dr. Mahesh sir. Sir, can you share your screen? By the time I'll just share your introduction. Yeah, I'll invite Dr. Mahesh Singh Sharan Singh. After completing his MBBS at Lokmanya Tilak Municipal Medical College, Sion, Mumbai, went on to Shyam Shah Government Medical College, Rewa, MP, to earn his MS in ophthalmology with a fellowship in medical retina and uveitis from Shroff Eye Center in Delhi and a fellowship in vitreoretinal surgery from the esteemed LV Prasad Eye Institute in Hyderabad. He continued his specialized study. Dr. Mahesh has expertise in both medical and surgical retina, having had experience of more than 7 years in the management of complicated retinal problems in both adults and children. Additionally, he is passionate in education and skill transfer, helping him to shape the future of ophthalmologists. So, sir, please.
Thank you, Pratik ji, for such a kind introduction. Let me come back to the topic, just extending from neovascular AMD to now DME. And I'll be talking about the visual outcomes in DME when you have a 16 weekly interval of aflibercept injection, the efficacy of it. So here we will be talking about mainly a real world scenario and how in our practice does it affect and how do you translate from what the studies are showing. Can you all see my slides?
Yes, sir, visible.
It's not moving. Just give me a second. Yes.
Yes.
Okay, so my slides are moving freely. So this is the disclosure that I have. So to begin with, let's just introductory, I would like to tell about the global burden of diabetes. It has kept on rising over the last decade, and projected number of patients who will be projected to have diabetic retinopathy is projected to be around 40 million over the 2045 year that we are expecting. So that's a huge, almost double the number that has been noted in 2020. So seeing the disease burden, we need a solution for these diabetic retinopathy at present. So the vision loss is the most feared complication that patients have. When you ask them, there was a study done in US by Bromer and Strain. They usually studied the different complications related to diabetes involving the heart, kidney, and the circulatory system. Most of the patient, around 50% of them, were concerned about the loss of sight because that would directly affect their day-to-day activity. And the effective treatment that we have to provide to these patients who have diabetic retinopathy, even gaining a single line on ETDRS chart, it changes their life drastically. Just one line change can let them have reading newspaper or drive at night. And gaining two lines mean they can perform their near function like reading or doing some cooking or tools. And you see, when they are gaining three lines, that is 15 letters that we are talking about, the color perception improves. If they have the vision more than 20/40, that means they have a driving license in majority of the countries. So that's a good change in the basic daily activities of the patient when they gain with these interventions. So here, landmark trials, Vivid and Vista, that were done in diabetic macular edema, they told us about how good is aflibercept when it is injected every 8 weekly and when it is injected every 4 weekly in the patients with diabetic macular edema. And DRCR net protocol, this basically in protocol T, it again suggested the 2-year outcome of the different injections, aflibercept compared with bevacizumab and then compared with ranibizumab. So both these landmark trials gave us different ideas. How does this injection work and help in the patients with diabetic macular edema? We'll talk about more of these in Vivid and Vista. Vista basically was studied in USA, where we studied the effect of injection aflibercept over the 4-week, 8-week, and 12-week interval over the period of 2 years. So there, what we had understood, the visual gain was around 10 to 12 letters in the patients over the period of 1 year, and it has maintained over the 3 years to 5 years interval. So if you see the number of injection later on after the injection, the studies was done, was around 3.4 in 5 years. And what we came to understand is aflibercept is a drug of choice in the patient who had a baseline best corrected visual activity less than 69 letters. Or if I have to simplify for you, if the patient has a vision poorer than 612, aflibercept was the injection of choice to be injected. And when compared with ranibizumab, over the period of 1 year, the drying effect was faster with aflibercept compared to razumab and the bevacizumab. And when you go through the 2 years or the longer outcome, they both were almost similar, showing no such difference as such. And superiority of aflibercept was mainly in the patients who had worse vision to begin with. And that's where the role comes. So moving ahead, aflibercept was also noted in many of the trials where protocol W, protocol AB, ACT, and V, all of them studied aflibercept very rigorously, and they have come out with aflibercept being the molecule of choice in most of the scenarios. In this Violet study, where the long-term benefits of aflibercept was studied in DME, and here also we had to see with 8 weekly injection aflibercept on a fixed regimen versus treat and extend and versus PRN regimen. All of them, when compared, showed that the treat and extend every 8 weekly was a superior one if we have to see the number of clinical visits that the patient had. Otherwise, if you see the vision gained or the letters on ATDRS chart was comparable in all the three. There was not a major difference. But the number of visits for a patient matters too when you talk about the later real world clinical scenarios. And YBIM study is the other study where the 57% of the patient who with aflibercept injection required injections fewer in 3 weeks. In the 3 months, they were requiring injection more than 3 months or equal to 3 months at the end of the 2 years. And the letters gained were around 9 to 10. Hirano et al. Is the other study which studied treat and extend therapy with aflibercept. And if we have to see the outcome, which was noted, is again similar over the period of 2 years. 67% of patient had maintained their visual acuity with the every 4 monthly injection. And the number of injection at the 2 years baseline was 11, and it extended barely by aflibercept when injected in this JADE study again goes to point out the same things, that the mean number of injection at 52 weeks, that is at 2 years, was around 7.7 or 7 to 8 injections, and proportion of patient who required treat and extension beyond were 87%, and the patient having dry retina at 1 year was almost half of them, 51%. So in prospective trials also the similar results are found. So if I have to summarize, aflibercept can help you achieve clinically better vision at 1 year interval and a faster drying rate when you compare it with the other anti-VEGF injections. And it is the only biospecific protein that is designed to act on both VEGF and placental growth factor. It is known to have a proactive dosing where the treatment burden is lesser with with aflibercept when you compare it with the other available anti-VEGF injections. And overall, when you see the treatment of DME, it has a combined effect of the systemic control as well as the injections that can maintain a vision for a longer period of time. You can see over the period of 5 years in different studies, we have seen the aflibercept injection has been proven safe and has been given good results with dry eyes. So that translates to good maintained visual acuity in these patients. So with this, I end my presentation. I open the forum for discussion. So I welcome everyone with their questions and queries. If they have any, I would love to answer them.
Sir, there are a few questions in the chat box. Can we take those questions first?
Okay, sure. We can go one by one.
Sure, sir. So there
Yes,
is a
please.
question from Dr. Swapnil. Which anti-VEGF agent do you typically choose as first-line therapy for treatment now DME and AMD cases? Like this question is for both the speakers.
Dr. Umesh, you want to go first or?
So first line I'll consider as aflibercept because we have seen that it is providing a long-term good effect on the retina, means the edema is decreasing, good drying effect, and for longer duration.
To add to so if Swapnil, if I have to answer this, in my practice, what we have studied through different what do you call evidence-based practice that we follow right now, anti-VEGF that we choose as a first line in DME specifically, if I have to tell you, are based on what is the presenting vision of the patient, what is the central subfield thickness that you note on OCT. So those two are taken into consideration, and also the economic aspect of the things. And if taken into consideration, the visual acuity is better than 20/40, then any of the three available injection, that is bevacizumab or ranibizumab or aflibercept, are known to have almost similar effect. So you can choose any of the three. That is what I do. I give the patient choice. You can choose between the three. But if I know the presenting visual acuity in the treatment naive cases is worse than 20/40, then definitely the preferred injection is aflibercept over the others. And in AMD, almost similar that I just suggested. I hope that answers your question.
Yeah, thank you. Thank you, sir. Sir, one more question is asked by Dr. Ruhi. So how frequently do you review treatment naive patients after initiating therapy?
So, Dr. Ruhi, what we do is when you inject the patient for the first time, the treatment naive, be it any injection, any medicine, when you inject them first time, we usually see them at 4 weeks and we judge based on 4 week outcome, how are we going to proceed with the further therapy.
Yeah, thank you. So one more question from Dr. Akash. How do you improve adherence to long-term treatment?
So, when it comes to diabetic macular edema or neovascular AMD, I guess Dr. Umesh would also add after me. Here, adherence to treatment is something that you need to prime the patient at every visit. You can't bombard them with the idea of 7, 8 injection, whatever I showed in the studies, the landmark trials, Vivid, Vista, and all these. They were all talking about 7 injection, 8 injection, 10 injections. So we don't talk about 10 injection right at the first interval. We keep on what do you call priming the patients at every visit. You just motivate them to not leave the treatment midway because sticking to treatment is known to have benefited the patient in the long term. And these injections are known to be very safe over the period of time. And very, very few patients tend to have intraocular inflammation over the course of years. So to stick, ideally, what we do is we keep on motivating the patient, involve them, and show them how they have improved with their OCTs being done at the regular intervals and it being shown to them. They become part of the treatment rather than you just treat them as somebody who has just come and you gave them the injection and sent away home. You make them part of the entire treatment. So they are interested, they are more concerned what is happening with them. You are with them at every stage of their treatment and improvement. That recovery is a journey. So that's how you make change. Dr. Oves, please.
So whenever the patient is presenting, we have to tell them about the loading dose, like every month, one monthly, for 3 months. And then after the third injection, we have to tell the patient whether the edema if the edema has improved, then we have to tell the patient and keep them motivating that the edema can recur. And for that, you have to come to back to the hospital for the checkup and for the injections. So main thing is motivation only. If the patient get demotivated, we might get it lost. So this is the thing. And there might be the loss of vision in future if the patient doesn't present again.
Yes, yes. Thank you. Thank you, sir. So that was really a practical approach that you have given on. So one more question from Dr. Renuka. So do you routinely administer a loading dose? If yes, how many injections and both in AMD and DME? Ovesh, sir, can you please answer that?
Yes.
Yeah.
So we usually give loading doses of 3 injections at 1 monthly injection, 1 monthly interval, both in AMD and DME. And then we follow up according to the edema which is present after 3 injections.
This is a very good question brought up by Dr. Renuka. Here, a little bit of difference from Dr. Oves's practice that I have in my practice. What I usually do is I don't go with loading dose in every case of AMD and DME. So what I do is give one injection and then assess about the second injection. Usually it comes in as a maintenance, the second injection. Even though if I get a complete drying effect with single injection, I don't let the patient not be treated and extended with the second one. I usually go for second injection as a maintenance, but don't go for a 3 loading dose back to back. I usually treat patients with single injection and the second as a maintenance based on how much is the drying effect. If I note the drying has completed with 2, I don't go for the third as long as they don't show any signs of fluid or what do you call IRF or SRF recurring back.
Great. Thank you. Thank you, sir. So, yes, Dr. Renuka has one more question. We also follow PRN protocol. Okay, so she is also saying that we also follow PRN protocol, but looking forward to try for treat and extend in few cases. So, great, great. Thank you.
So if anyone has any other questions, like forum is open, you can ask the questions, like you can speak up or you can put it in the chat box, whichever is convenient to you. Because we all are here to like learn from each other here. So yeah.
Okay, so on behalf of Bayer, I would like to thank Dr. Ovesh and Dr. Mahesh sir for giving a very nice and a wonderful scientific discussion on aflibercept. And I would like to thank all the participants, those who have spared their valuable time for listening this scientific discussion. So thank you, sir.
Thank you, everyone. Thank you,
Thank you,
Bayer, for
Prateek.
this opportunity.
Yeah.
Thank you so much, sir. Both
Yeah.
the presentations were very good, sir. Thank you so
Thank you
much.
so much.
Thank you. We are good to close. Thank you.
Tech team, we are good to close.
Okay, sir. Thank you.